My name is Brendan Erskine. I'm the DSA or Angiography and Fluoroscopy Supervisor at the Alfred Hospital in Melbourne. Today my lecture is going to be on vascular and angiographic pathology. I'm going to take you through various images, CT, MR, particularly angiography, displaying vascular pathology. For today, the learning outcomes will be defining vascular pathology, identifying the strengths and weaknesses of each imaging modality, and identifying the characteristic signs of vascular pathology. Here's some suggested reading. We're going to define vascular pathology and identify the appearance of vascular pathology on angiographic images, whether that be CT, MR, or catheter-based angiography, and look at some case presentations. Just a brief overview or review of the vascular system, which involves the arterial, venous and lymphatics, and obviously arterioles and venules as well. So the arteries and veins contain the same three layers. So the tunica intima, the media and the adventitia. The media on the vein, or the muscularis layer, is a lot smaller, and the outer layer, the adventitia, is thicker on arteries. When characterizing vascular pathology, we can roughly categorize them into, is a vessel narrowed? Obviously the extension to that is it completely occluded. On the opposite side of that is a vessel more enlarged or dilated than it normally is? Is the vessel transected or ruptured? And angiogenesis is the recruitment of arterial feeders into a neoplasm. When looking at narrowed vessels or stenosed vessels, when we focus on the arterial side, that could be due to many causes, so potentially atherosclerosis or plaque buildup, vasospasm, fibromuscular dysplasia, or external compression. On the venous side, a narrowed vessel could be caused by a partial thrombosis, vasospasm, fibrous narrowing, or external compression. There are various reasons for an occluded vessel. Arterially, it could be acute, as in an embolic clot, or a transected or ruptured vessel. Chronically, it could be an accumulation of plaque due to atherosclerosis. There could also be an acute embolic clot in the venous system. A chronic condition known as thromboembolic disease is the chronic accumulation of embolic clot in the venous system, in the pulmonary circulation, or thoracic outlet syndrome. There are various reasons for an enlarged or a dilated vessel. One could be an aneurysm. Another one could be hyperplastic vessels feeding vascular tumours, and also pre- or post-stenotic dilatation. In the venous system, this could be due to varices, so enlarged vessels finding a path around a narrowing, or a venous aneurysm. Combination of venous and arterial can result in arteriovenous malformations or arteriovenous fistulas, which is shunting across the capillary bed. When categorizing aneurysms, we categorize them into true and false or pseudoaneurysms. So true aneurysms involve all three layers of the vessel wall. These can include saccular or berry aneurysms, fusiform or mycotic aneurysms, which are due to an infectious cause. A false aneurysm or a pseudoaneurysm is flow into the vessel wall, but only containing one layer of the vessel wall. It can also be a dissecting aneurysm. When reviewing ruptured or transected vessels, uncontained ruptured vessel is often bleeding on an angiogram. A contained could be a false aneurysm or pseudoaneurysm, or a dissection down the vessel wall caused by trauma or hypertension. So which imaging modality is best to view or to diagnose vascular pathology? Well, CT is a very quick modality. It does involve high radiation dose. It provides a detailed view of vasculature in three planes, but it only demonstrates anatomy and not flow. It provides additional information about the presence of extravasation and hematomas. You can get metal artifacts, and that makes it difficult to image stents and coils. MRI has a lower spatial resolution than both CT and angiography, but it's rapidly improving with scanners now available up to 7 or 15T. Majority of scanners are around the 3T. Some MR sequences can provide limited information about the vascular flow, but these sequences are often quite long and extend the whole scanning time for that patient to above 45 minutes. Real advantage is that it doesn't use ionizing radiation, but it does suffer from similar metal artifacts as CT. DSA, or catheter-based angiography, provides a detailed imaging platform for looking at vascular pathology, but it's only limited to where the contrast is being injected. It provides information about flow and anatomy. It is a highly invasive test, needing the injection of contrast through catheters, which are placed through a catheter sheath in the groin. It's high radiation dose and should only be limited to studies where an intervention or a treatment decision is likely. And it does require an angiographic team, which is a minimum of 4 staff, so 2 nurses, 1 doctor and 1 radiographer. I'm not going to look too into ultrasound and nuclear medicine, but I'll give you a brief overview of ultrasound. It's an ideal screening tool because it's quick, non-ionizing and cheap. It only has moderate sensitivity and specificity for certain vascular pathologies, and it's highly affected by the patient habitus, pathology and the skill of the sonographer. Nuclear medicine is more of a physiological test. It has low specificity for vascular pathology and is a moderate dose to the patient. So when categorizing the angiographic appearance of vascular pathology, so catheter-based angiography, you've really got to first possess a thorough understanding of the patient's clinical history, and any imaging findings should be matched with that clinical history. So for narrowed and dilated vessels, I remind again that angiography only demonstrates, this is catheter-based angiography, demonstrates the luminal vessel where the contrast is being injected. CT can provide a detailed view of the vessel wall, and it makes it particularly important for thoracic and abdominal aneurysms and dissections. So the questions we've got to ask is, does the vessel have a smooth or corrugated or irregular appearance? Are there any collaterals present? When looking for acute clot, are there any filling defects? Is there slow flow or any vessels that you would expect to fill not filling? When looking at bleeding on catheter-based angiography, is there contrast where it shouldn't be? Is there extravasation of contrast? And are there vessels that are blunted that perhaps have been transected? In high flow states such as arteriovenous malformations and arteriovenous fistulas, we must look for dilated vasculature. And is there rapid flow between the early filling veins, between the artery and the early filling veins after an arterial injection? Vascular tumours, we look for abnormally dilated vessels feeding the vascular tumour. We look for the characteristic tumour blush. We must note that not all tumours are vascular. So whether or not there is or isn't a tumour blush doesn't rule out the possibility of a tumour. We must also look for the potential for extra vessels, also known as angiogenesis. So I'm just going to focus on some DSA image here. We've got an arch aortogram. You can see we would expect the vessel to be nice and smooth all the way along. We can see here narrowings in the brachiocephalic, the left common carotid and the left subclavian. And this is an arch that has atherosclerosis or plaque. Same thing in the common carotid. So this is the common carotid bifurcation here. We're seeing a high degree of narrowing or stenosis, and this once again is caused by plaque. This is atherosclerotic disease in the lower limb. So this is the knee joint down here. Hip is up above. You can see here narrowings all the way along the vessel. Coarctation is a narrowing of the aorta. It's shown on various modalities here. So A is CT, B, C and D are, A is MRI, B, C and D a CT image is volume rendered and surface shaded. This is the imaging of the aortic arch in a sagittal plane on CT with a stent in this case. The same angiographic imaging of the same patient demonstrates a very dilated ascending aorta with a highly narrowed coarctation and dilated descending aorta. There are also presence of enlarged internal thoracic vessels, which are providing collateral circulation around the narrowing. When identifying acute emboli, we must look at what vessels are not filling. So you can see here we've got a lateral and a PA angiogram. This is of the internal carotid. So pretty easy to identify on the PA. We would expect middle cerebral to be coming out here. And that same territory for middle cerebral on the lateral is this area here. So after the clot has been removed and vasodilator is given, you can see here that we've re-established flow into the middle cerebral on the PA and lateral. This is a trauma case where a patient had a transected right renal artery. We can see here a lot of devascularization, or we're not seeing a kidney show up on this area. We're actually seeing this area here, and we can't see this on angio because we're only seeing where the contrast is being injected. It has a large hematoma around it. So the kidney that we would expect to fill should be in this region. And we're not even seeing any bowel, and the hepatic artery is actually being pushed out of the way and the bowel being pushed to the patient's left-hand side due to this hematoma. This is a case of chronic atherosclerosis. So on the left internal iliac, this is an LAO projection. We see here nice smooth flow down the left common iliac. But on the right side we see an occlusion with collaterals and re-establishment of the right external iliac. You can see here really nice definition of collaterals around the lumbar and median sacral artery. Another occasion of complete occlusion with lots of collaterals in the popliteal artery. Similar case here, so knee joint, popliteal artery, massive collateral, and then reforming the popliteal artery distal to the occlusion. Venous stenoses can be caused by a few different things, such as external compression, vasospasm, or in this case here, it's caused by needling of an AV fistula. So an AV fistula is a fistula created for the purposes of dialysis, and repeat needling in this area has caused a fibrous narrowing of that vessel. This is an example here of a patient that's had external compression from a mediastinal tumour. Once again, that we can't see, we can see the effects of that. It looks like an atherosclerotic disease, but you don't get atherosclerotic disease affect veins like you do arteries. So this was due to an external compression by a tumour, which was demonstrated on CT. You see here very nicely a really large collateral going around this narrowing down the azygos or hemiazygos vein. This is external compression of the IVC by a mediastinal melanoma. So this is a metastatic melanoma into the retroperitoneal cavity that's almost completely occluding the IVC here. You see the IVC being compressed here, and on angiogram, a diffuse narrowing across the IVC. Acute pulmonary emboli or acute PEs result generally of accumulation, an acute accumulation of clot residing from a deep vein thrombosis, generally in the leg. And we can see here filling defects in the right. We actually see a little bit of a filling defect in the left pulmonary trunk as well. And we're not seeing a nice capillary blush where we would normally see vessels or enhancement of vessels with contrast. This is a chronic occlusion caused by a condition called Paget-Schroeder's disease, which is a chronic occlusion of the subclavian vein by the clavicle and the first rib, and that's caused complete occlusion with formation of collaterals. After treatment with a balloon and first rib resection, we've restored flow, and you can see here the path of least resistance is along this vessel now, the major vessel, and we've lost those collaterals. Here's a case of another pulmonary emboli case, but this is a chronic accumulation of pulmonary emboli causing pulmonary hypertension. So here's the left pulmonary artery. You can see here narrowings there. You can see here wedge artifacts where we're not seeing distal flow. Another good example on the right, big wedge artifacts here where a clot has embolized that vessel. We should be seeing filling all the way out to the periphery here. This is a case of vasospasm post-aneurysm clipping, which can result from the irritation on the brain of subarachnoid hemorrhage. You can see here along the colossomarginal vessel, we're seeing kind of like a sausage appearance to the vessel here, which is a result of vasospasm. There's a different patient here, similar indication though for vasospasm. We're seeing narrowed vessels all the way along the anterior cerebral. When we look in the PA, we've got anterior narrowing and middle cerebral artery narrowing. When we look in the capillary, what's interesting is we've got a wedge artifact where we should be seeing perfusion. So a vessel that's come off the middle cerebral, anterior temporal, or a vessel from the anterior cerebral has actually vasospasmed so much that it's occluded, so we're not getting flow into that area. You see that big wedge artifact there. A couple of examples here of intracranial saccular or berry aneurysms. They're fairly common in the brain. It's a large ACOM aneurysm. This one here is an aneurysm arising from the carotid siphon region. And here's another ACOM aneurysm in an oblique projection. This is a common spot for aneurysm at the basilar tip, where it bifurcates into the right and the left posterior cerebral artery. This is an example of what looks to be a saccular aneurysm, or a berry aneurysm. It was in fact a fusiform aneurysm. So when we did a 3D spin, we were able to identify a vessel coming into the aneurysm and then back out, whereas a saccular aneurysm is an outpouching of the standard vessel. So on a sagittal reformat, you can see here the vessel coming into the aneurysm, the big sac there, and then a vessel coming out. And that does highly affect the treatment available for that aneurysm. This is a pseudo or false aneurysm of the thoracic aorta. You can see here very nicely on CT that whilst contrast is only getting into this part of the aneurysm, there's actually a ring of thrombus around here, which gives a better indication of the actual size of the aneurysm. So as this gets bigger here, it may actually not demonstrate that much filling, but we can continue to fill the outside with thrombus. Here's an axial CT demonstrating the same thing. So here's on angiography. This is a standard kind of LAO projection with a pigtail catheter. We're seeing filling into this aneurysm. Remember, we don't see the thrombus around the outside. A reverse oblique is showing a little narrowed entry to the aneurysm with filling. This is an abdominal aortic aneurysm, and once again CT is a very good modality to look at the overall size, not just the internal lumen of the vessel. You can see here quite a large aneurysm, but even larger amount of thrombus around the outside. This is that same patient on angiography. This is catheter sitting up above the celiac trunk and demonstrating the width of this aneurysm, and the aneurysm actually extending down to the common iliacs. This is a case of traumatic dissection. Once again, a false aneurysm, so a contained bleed. So on X-ray, we can see here a widened mediastinum. On CT, we see thrombus, or extravasation hematoma around the aortic arch with a little dissecting aneurysm into the wall. So this was brought round to angiography for treatment via a stent. So catheter was placed into the ascending aorta and injected, and contrast was injected, and it showed that dissection. And a stent is then placed over the top of this area to prevent flow into that dissection. This is a case of a spontaneous dissection, so not traumatic, and that dissection, you can see here the intimal flap there is extended all the way down the aorta. So on angiography, catheters were put in both the true lumen and false lumen. You can see here the true lumen is supplying the celiac trunk and SMA, and here's an oblique picture of that. The false lumen was supplying the renal artery and IMA. is an example of a high flow state, or an AVM, arteriovenous malformation. It's characteristic of shunting across the capillary bed, and also dilated venous channels on the outflow. So axial CT-like image, actually created from an angiogram, shows the nidus of the aneurysm and a large draining vein. Here's that same patient on angiography. There's the PA and lateral. You can see here the large AVM. This is a facial AVM coming off the external carotid. See here a very large blush. So these are all arterial branches. They're enlarged. They're bigger than what they normally would be because this AVM is sucking flow into them and causing enlargement of the vessel. This is an AVM in the foot with previous treatment by coils. You can see early arterial, lots of branches there with dilated veins on the outflow. It's an example here of a dural AVF, or an arteriovenous fistula. So instead of an intermediate capillary network like an AVM, the AVF is basically a direct connection between the artery and the vein. It shunts across and bypasses the capillary bed. So you can see ophthalmic artery and then straight into the superior sagittal sinus. This is a nice case of a traumatic AVF, which was caused by a stabbing. So the patient was stabbed anteriorly and stabbed through their right renal artery and then into their IVC. And we can see here we've established a connection between the right renal artery and the IVC. See here very nicely some hematoma on the CT with extravasation. This is a case of FMD, or fibromuscular dysplasia, which affects the media layer of the vessel, so the muscularis layer. It causes this kind of beaded appearance, which looks like a stenosis, which is a stenosis, but it looks like an atherosclerotic narrowing, but actually has a bit more of a beaded, irregular appearance than compared to atherosclerosis. It's another case of FMD. You see FMD along here, but also with an associated aneurysm. This is of the left renal artery. This is a patient with dilated venous varices caused by portal hypertension. So this patient has a poorly functioning liver, which is causing back pressure into the portal vein. So the flow is unable to get out through the liver into the hepatic veins, so it has to find another way there. So it's caused the enlargement of these varices, esophageal varices. This patient here presented to CT with ascites and bleeding, and this was actually a balloon put in their stomach to stop them from bleeding. This is a patient who's having a procedure to shunt, bypass their liver. It's basically what they call a transjugular intrahepatic portosystemic shunt. So it's basically where a catheter is put into the hepatic vein, and then a needle is passed across the liver into the portal vein, and a stent passed across. So while at the same time here we can actually see the degree of venous varices there, extending all the way up into the diaphragm. There's another occasion of venous varices, but instead of esophageal varices, these are umbilical varices. This is an occasion of liver trauma. So on CT, on the portal venous phase here, coronal, we can see here this is portal vein, and this is extravasation into a large hematoma. So these are axial slices. We see an early arterial blush filling into the portal vein, and then delayed filling into that hematoma. So this was that patient around an angio. We can see here we should be seeing flow or perfusion all the way out to the periphery here, but we've got a large amount of fluid sitting there, and we've got a bit of extravasation there with a hematoma in this region. This is an interesting case of renal trauma. So this is a vessel here, a lower kidney or lower renal vessel, which showed a nice kind of blunted vessel. When the catheter was introduced quite closely and injected vigorously, it actually demonstrated the bleeding from that blunted vessel. It's a case of pelvic trauma. So on CT here, fracture of the inferior pubic rami with active arterial extravasation. That's the axial, and this is the coronal. This is that patient there. So this is a angiographic catheter introduced from the left-hand side up and over the aortic arch into the right internal iliac artery. And we can see here flow and a bit of extravasation in the obturator artery. So right over the level of the fracture. Interesting case of someone who'd received a shotgun to the lower limb. You can see here buckshot demonstrated on the standard PA or standard AP tibial shot. They were moved directly to theatre. What theatre had demonstrated that the vessel had been transected by the buckshot here. You can see here on the angiogram a blunt narrowing and occlusion of the vessel with collateral circulation. You can see here on the lower angiogram we're getting collateral circulation and reforming of lower vessels. Vascular tumours are generally imaged in CT, but occasionally we're asked to embolise or categorise the filling of a vascular tumour in angio. This is a very vascular tumour, a hemangiopericytoma, and this is injection into the splenic artery and shows collateral circulation or collaterals and feeding vessels into this hemangiopericytoma. This is a left renal shot. We can see here a blush outside of the kidney, which is the tumour. When we injected the SMA, we've got a vessel that supplies the tumour from the SMA and similar from the IMA. So it's really recruiting a lot of flow from various vessels in the abdomen. Uterine fibroids are benign lesions but very vascular. We're occasionally asked to embolise these due to pressure on the uterus and pressure on the bladder. You can see here this is internal iliac. We're seeing quite an enlarged uterine artery, and we're seeing distal flow into the fibroid. On the right hand side, this is once again the uterine artery. You can see here an indication as to how big this fibroid is, and it's actually causing impression onto the bladder. Occasionally we see pathology that is more of an incidental or a curious kind of pathology or anatomy. This is called a venous angioma and presents some nice images of these dilated outflow tracts from this venous benign lesion. Often they're called incidentalomas because they don't need to be removed, they just provide interesting imaging. So to summarise this presentation, it's important to understand the strengths and weaknesses of each imaging modality in the imaging of vascular related pathology. You must understand and match the imaging findings with the clinical history, because there can be various indications and demonstrations of pathology on each modality. We need to look for the characteristic signs of vascular pathology. Is a vessel narrowed? More narrow than what it should be? Is there dilation? So is it bigger than what it should be? Are there absence of vessels that you would expect to see filling? Is there recruitment of vessels? And that's the end of the show.